Hello, everyone, and welcome to today's webinar, Getting to the Heart of Cardiovascular Risk. It is being given by Dr. Jacob Kornberg, who completed his medical degree and 4-year surgical residency at the University of California in Irvine. And Dr. Kornberg is currently the Director of Professional and Clinical Services at the Metagenics Functional Medicine Research Center in Gig Harbor, Washington. That?
Yes.
Hello, Dr. Kornberg.
Thank you. Well, good morning or afternoon, depending where you're listening. And thank you. And welcome to this first in a series of webinars. In the next 4 series, we'll be looking at an innovative approach to a patient that has type 2 diabetes. We're looking at it through 4 different perspectives. Many of our patients, especially complex patients we see in our clinics, you can approach them from a different approach depending on the patient's main complaints or the condition that seems to be the most threatening or concerning to the patient. So we're looking at this type 2 diabetes from cardiovascular risk. The next seminar will be on male health issues. The third will be looking at his gut issues. And the fourth and final will be actually looking at blood sugar control. So this patient is a 43-year-old African-American male. He presented to our clinic for our diabetes trial. The patient had a 13-year history of type 2 diabetes. He was maintained on human insulin, checking his blood sugar 3 times a day. He was following any consistent dietary recommendation. At a normal weight until approximately 3 years ago, but has gained 50 pounds since then. At the same time, 3 years ago, he was put on antihypertensive medications when blood pressure reached 185/100. He was off when his company downsized about 3 years ago, and this has put a financial strain on his family. Also, he's caring for his son with autism, which causes a 4 out of 10 stress in his life. As far as diet, is not only following any diet restriction, is on a non-calorie restricted American diet. He exercised until 2 years ago, but because of foot discomfort, he's discontinued. A smoker, probably 20-pack years, but he drinks about a cup of caffeinated coffee per day. Current conditions are obesity, he has arthritis, benign prostatic hypertrophy, erectile dysfunction, indigestion and heartburn, flat feet for which he wears orthotics, and neuropathy to his feet, some mild tingling. We'll go over the other and the next 3 seminars. As far as his past medical history, he had rotator cuff surgery. His family history, his father had early cardiovascular disease at 49 years old, type 2 diabetes, hypertension, and hyperlipidemia. His mother has hypertension and has obesity. His brother also has cardiovascular disease, hypertension, obesity, hyperlipidemia, and has had prostate cancer. The patient's present medication is NPH human insulin, 50 minutes twice a day. He's on metformin, also 100 milligrams twice a day. He's on candestartin, which is an angiotensin II receptor agonist for hypertension. Atenolol, which is a beta blocker for hypertension. He takes acetaminophen for pain occasionally, and he's on essentially Viagra for his erectile dysfunction. As far as objective information from his exam, his weight is he's 69 inches high, weight 245 pounds, which makes a BMI of 36.2. His blood pressure is elevated at 144/82, pulse normal. His waist to hip ratio was slightly high at 0.95, but his medical symptom score was about 27. Physical examination, essentially unremarkable, except for being overweight. I really could not elucidate any decreased sensation in his feet. Laboratory work that we did, essentially a lipid panel, shows that his total cholesterol was elevated at 210, triglycerides markedly elevated at 264, was low at 32, calculated LDL, in the guidelines, but probably not optimal. Total HDL ratio was 2 at 6.5, with the optimum being less than 5. And indication of maybe metabolic syndrome, divided triglycerides by the HDL ratio, shows this to be markedly elevated at 8.3 rather than the optimal at 3. Other laboratory work shows high sensitive C-reactive protein indicating inflammation was elevated at 3.1 and a high risk. His homocysteine was too high, 13.4, showing that he might have some problems with methylation. His fasting glucose was elevated 111, but not bad for a diabetic. Hemoglobin A1C was still elevated at 6.9, and urine albumin excretion rate was elevated at 32 micrograms per minute, and this would show that he had microalbuminemia, and we'll talk about that. And other blood chemistries were essentially normal. So our initial protocol for this gentleman was to start him on first-line therapy on a modified Mediterranean low-glycemic food plan. He was placed on exercise and purposeful movement, and we started working on reducing stress and giving him exercises for his stress reduction with his family situation. He was on Ultra Meal Plus 360 medical food, 2 scoops twice a day. Decided to use high concentrated DHA as an omega-3 fatty acid, although you might just use a more balanced omega-3 fatty acid product. We put him on coenzyme Q10. He's actually started on 200 milligrams per day. Additional things that we thought we might want to use, assuming that this initial program did not bring his cholesterol down or did not bring his glucose down, we were thinking of adding extended release niacin formula maybe to help with homocysteine levels, although there is activated folic acid in the meal product. We might use an advanced formula that included green tea, cinnamon, and alpha-lipoic acid to help with healthy insulin activity and glucose leveling. And then the list shows, depending on his religious and personal beliefs, we actually suggest 1 glass of wine per day. So to start our discussion, we're kind of looking at endothelial dysfunction. We'll see how this works. Well, endothelial dysfunction is a very significant common denominator with cardiovascular disease. So what we know is that shear stress, and this is the mechanical force that is created along the edge of the endothelial cells by moving blood, creates a cascade through several kinases, phosphatidylmyostinol 3 kinase, and it elicits a endothelial nitric oxide synthase enzyme from endothelial cells. This, associated with oxygen and L-arginine, several cofactors, especially calcium and tetrahydrobiopterin, creates nitric oxide and citrulline. Now, nitric oxide will increase cyclic guanosine monophosphate, which allows for platelet inhibition so that platelets don't stick to the endothelium. Also, simultaneously inhibits monocyte adhesion, and stimulates an enzyme, guanylyl cyclase, which converts guanosine phosphate to cyclic guanosine monophosphate, and this has the relaxing effect on the smooth muscle and inhibits smooth muscle cells from overgrowing. And this creates a relaxation of the artery wall in relationship to increasing blood pressure. Now, interesting, because nitric oxide production is dependent on glucose, so if we have insulin resistance with decreased uptake of glucose, you have decreased nitric oxide and decreased ability for the blood vessels to relax. Also, in a diabetic, when you have hyperkalemia through another kinase, you actually inhibit the formation of eNOS. This increases the eNOS, and hyperglycemia, you have inability for the blood vessels to respond to variations in the blood pressure, which leads to endothelial damage. From the literature, we show that this new concept of endothelial dysfunction and measuring it reflects a very early prototype prone to atherogenic, and then is a marker for inherent atherosclerotic risk in individuals. And we can pick this up sometimes even before we see atherosclerotic changes. So function in either peripheral vasculature or coronary endothelium was shown to be an independent predictor of cardiovascular events and provide valuable prognostic information that was different from the conventional risk factor assessments. So we want to look at the what happens when there's damage along the endothelium. So along here. So if the blood vessels can't relax and you get increased blood stress, you get damage. And right here you get activated platelets put on chemokines. These chemokines mark out an area of possible damage. Then, with decreasing nitric oxide, so the monocytes now become sticky. They stick to these chemokines, and they work their way through and migrate into the lumen, the vessel wall, where they transform into macrophages. Which of oxidized LDL makes its way also into the vessel wall. Macrophages gobble up this oxidized LDL and the byproducts of their digestion create foam cells. Foam cells then accumulate. The endothelial muscle smooth cells become more prolific. You get a formation in the beginning of atherosclerotic disease. So, in a nutshell, the process, let's kind of look at how we would assess the risk in this patient. So, there are certain risk factors that we cannot change. That increasing age is an increase of cardiovascular disease. There's increased cardiovascular demand, certain hereditary inheritances increase risk. This one, our patient had all three of these. But there are major risk factors that we cannot modify. Smoking, hypertension, high cholesterol, physical inactivity, obesity, diabetes, stress, too much alcohol. Our patient had most of these major risk factors. When we look at cardiovascular disease, we realize that we're not alike. We're not created alike. Age has a factor. 80% of people who die from coronary disease are above 65 years old. Gender, men have greater risk of heart attack than women, and they seem to have it early in life. older ages, we have heart attacks that are more likely to die from them within a few weeks. On the heredity point of view, we know that children of parents with heart disease are more likely to develop heart conditions themselves, and then certain ethnic groups, African Americans, Native Americans, Native Hawaiians, and some Asian Americans seem to have a higher risk of cardiovascular disease than Caucasians. We look at what are the recommended goals for various risk factors in diabetes by various organizations. Well, first, we want to get the blood pressure down below 130 over 180. We want to decrease the LDL, the oxidizing LDL, below 100. And if we know the patient has cardiovascular disease, the recommendation is to get this lower, less than 70 milligrams per deciliter. For HDL cholesterol, it's less than 130. For HDL cholesterol is greater than 40 milligrams in men and greater than 50 milligrams in women. Triglycerides should be below 150, and if they smoke, they try to stop smoking. So these are the recommended goals for a person with diabetes for reducing cardiovascular risk. If we look at that here, if it has no disease, there is an increased risk as you get to a high CRP greater than 3, almost double risk. But in metabolic syndrome, you already start almost twice as much of having cardiovascular disease as the person with no disease, and almost 3 times the risk with high CRP. If you add diabetes to the mix here, with a low CRP is having over 3 times the risk of cardiovascular disease, but almost 8 times the risk of a patient with an elevated CRP. So diabetes and cardiovascular disease are tied together. 17.1 million Americans diagnosed with type diabetes, and there's a lot more that are undiagnosed. The risk of cardiovascular disease is 2 to 4 times in people with type 2 diabetes, and cardiovascular disease is the cause of death in 80% of the people with type 2 diabetes. So, why maybe I decided to look at the cardiovascular risks in a diabetic patient as our first perspective, because this gentleman has a significant risk of having a cardiovascular event. If you get diabetes and cardiovascular mortality, again, you immediately see that those with diabetes have a marked increased mortality rate as those that are non-diabetic. These are the number of risk factors for cardiovascular disease, whether they're smoking, dyslipidemia, hypertension, high CRP, etc. We can evaluate a TARE risk assessment by 2 tools that developed. The first is the Framingham risk score. This is something that has been around for a few years. It's at age, blood pressure, diabetes, your smoking, total cholesterol, and HD cholesterol, and use an algorithm to calculate the risk of having a cardiovascular event within the next 10 years. Newer risk assessment tool, the Reynolds risk score, has added high sensitive CRP and internal history of MI to their algorithms, although the recommendation is not to use this in diabetics because diabetics already have such a significant elevated cardiovascular risk. But if you use the Framingham risk score for our patient that we just talked about, you with his age, cholesterol, HDL, blood pressure, on medications, diabetic, this has a 37% risk of having a coronary event within years. One of the things I tell clients is that it's not enough just to suggest that patients stop smoking. We really need to help direct a smoking cessation program, and I'm one that used in my office a lot. It's smoke it halfway and you're halfway there. You know, since tobacco is the best absorber of nicotine, what we will do is have the patient mark the Tarzan nicotine. We'll have the patient mark the cigarette halfway and smoke it only halfway there, halfway down. I found that once the patient gets on that for several months, they're ready for the next step in trying to quit smoking. Hypertension is a significant risk for cardiovascular disease, and study just shows that by the age of 70, 80, 75% of men and women will probably have hypertension, and it's a significant problem in our country. So 1 out of 3 adults of all ages have hypertension. Classification, according to the latest literature, is that the optimal systolic is 110, diastolic 170, normal is 120 to 180. But once above that, you go into the pre-hypertension area, up 140 over 90, 104 90, you become stage 1 hypertensive, up to 160 over 100, and that comes stage 2 hypertensive. Obviously, we would like most of our patients to be normal or potentially in the optimal range. This is a very interesting article that's going to pop up on your screen in a minute. This is about the white coat syndrome, and many of us tend to ignore it. But this article said there's 3 types of hypertension they followed. White coat hypertension, hypertension when you take your blood pressure at home, and hypertension when you go into the Safeways or you go into an ambulatory place and have your blood pressure taken outside the doctor's office. And showed that there was a significant increase in cardiovascular event if you had any of those compared to those patients who did not have hypertension in any one of those areas. As you added 1, 2, or 3 elevated hypertensions, your risk of mortality is. The patient that comes into you and says, "Oh, I just have white coat hypertension," that shows an increase in mortality and probably should be addressed. The major sequelae of hypertension are the heart. So if you look at a normal chest X-ray, this is the left ventricle. On with uncontrolled hypertension, tend to develop what we call left ventricular hypertrophy, and see how much larger the ventricle is in this patient's chest X-ray. If you look at this diagram, you can see how the muscle has hypertrophied and leads to poor cardiac output. A significant sequelae of hypertension has to do with damage to the kidneys. Kidneys start out as a nice, large organ that helps us detox, but with hypertension over time, the kidney shrinks down, becomes nodular, as is its function. If you look at this primary cause for kidney failure, from an article from 2005, you can see that diabetes and hypertension by over 70% of the cause for kidney failure in our population. Now, we talked a little bit at the beginning that our patient had an elevated human excretion rate. So we now know that this microalbuminuria is a significant indicator. So is any amount of albumin in the urine between normal, and there's actually 3 different tests you can weigh urine albumin rate is given to the lab. It could be different rates, or it could be a rate related to creatinine ratio, but it doesn't make any difference. They're normal, and there is an elevated, usually about 10 times higher than that, that's called macroalbuminuria, which is essentially the definition of actual kidney damage. But microalbuminuria is this area between normal and macro indicates to us that there is the beginning of kidney disease. We should take appropriate action to prevent macroalbuminuria and actual kidney failure. So this article, it reiterates what we just said, that indicates renal endothelial permeability, and denotes especially important because it signifies a very early indication of vascular damage long before you actually see end organ damage that can measure in kidney function tests. And the studies have emerged highlighting that microalbuminuria should be checked, and it's an independent marker of endothelial dysfunction that we talked about earlier, and cardiovascular disease. And then when you combine hypertension with people with microalbuminuria, like our patient, they have more frequency of developing left ventricular hypertrophy, carotid artery thickening, and other end organ damage as a result of the vascular permeability. Let's look at microalbuminuria compared to ischemic heart disease risk. Related to, on the bottom here is blood pressure. You will see that, yes, there's an increase of ischemic heart disease as systolic blood pressure goes up, but almost doubled with those patients that have microalbuminuria. This is becoming a very important marker to get on your patients, and you need to mark it because if you just do the regular urine, you normally don't pick it up. Cholesterol factor, we know that, and it's a risk factor with cardiovascular disease. But this article just shows that in diabetics, it's a significant increased risk factor in cardiovascular disease and mortality. So we want to try to control cholesterol in our diabetic patients. The parameters, instance, you see on the right are the thresholds, so total cholesterol, if it's above 200, we want to restart treatment. The optimal would be to have the total cholesterol below 150. HDL in male and female is a little different. Triglycerides, the threshold for treatment is above 150, but optimal, we'd really like to see the numbers below 100. Now, and this is this marker for metabolic syndrome, triglycerides divided by HDL. Really want to see this less than 3, but threshold is above 4. And LDL, of course, varies. Threshold treatment varies anywhere in the literature, but mostly agreed upon above 200. But I want to get it below 100. And as you saw, if there's actual cardiovascular disease, the literature now says we'd like the LDL below 70. This is an interesting article. The article said it took 136,000 patients admitted to the hospital for LDL. And what's interesting, you can see that LDL can't be the indicator of cardiovascular disease because over half the patients had an LDL that was actually lower than 100 in this study. So we have literature that now says that maybe LDL is not the end, but maybe you should be looking at like apolipoprotein B100 or ApoB. And it could be with or without ApoA. The ApoB is the bad actor, the bad apolipoprotein. And studies show to be superior to LDL cholesterol in predicting cardiovascular events. And so we go down that this ApoB to APO1 ratio could be a simple, robust, precise indicator and a great screening value during lipid-lowering therapy. The values we want to affect would be probably lower than 0.7, although some people go down as low as 0.5 to be optimal, but definitely any risk of ratio of ApoB to ApoA greater than 0.5 represent an elevated risk of cardiovascular disease. look at all the, and this is from the Women's Health Study, and looked at all major risk factor lab tests we can do. But the important thing, so here's homocysteine giving you between a 1 and 2 increased risk of future cardiovascular disease. Here is ApoB, almost 2 to 3 increased risk. But we know that high sensitive CRP and sensitive CRP combined with total cholesterol HDL ratio seems to give a significant risk factor cardiovascular disease events. And our patient, of course, in both of these. So in our clinic now, we check the HCRP on all patients because it seems to be a very significant ratio risk along with the ApoB, ApoA ratio. I just want to end this part by just saying that we know from all the statin studies, and we have to acknowledge them, there is a strong recommendation for diet, exercise, stress reduction, smoking cessation for patients that are at risk for cardiovascular disease. But let's not forget that a patient is diabetic or has a strong history of premature atherosclerotic heart disease and place them on a good trial of lifestyle medicine and they do not come around, we have to give strong consideration for statin treatment if their Reynolds or Frahan risk study is still greater than 5%, or if after a good trial of therapeutic lifestyle modification, their LDL still remains elevated, their high sensitive CRP is greater than 2, or cholesterol HDL ratio is greater than 5, then again, strong consideration must be given for statin therapy, especially if their risk still remains above 5%. And again, above recommendations, sometimes it's necessary to send a patient to a lipid specialist or cardiologist for further evaluation. Okay, anytime you mention statins, of course, I want to bring up several studies. Statins inhibit the synthesis of mevalonate, which is a precursor to both cholesterol and CoQ10, inhibits the biosynthesis and decreases the CoQ10 available from statins. And this article is on nitric oxide deficient hypertension in rats, and they measured the level of CoQ10 in various areas of the body, and they found indeed CoQ10 went down in the heart, went down the skeletal muscles, but did not go down in other places like the brain and in the liver. So patients on any type of statin therapy, even if it's a nutraceutical type of statin, should have CoQ10 replacement. So spend some time and kind of dissect our treatment protocol that we did for this patient. So therapeutic lifestyle program, that's more than a diet. We all know about first-line therapy. This patient was put on a first-line therapy plan, including nutrition, including exercise reduction, and exercise and stress reduction. So that from this, go from orange, improvements in dietary fat intake, exercise and stress management individually. So each one of these was an additive effect and decreased coronary vascular risk. And so you must have a multi-component program that focuses on diet, exercise, and stress management, and he recommends this is beneficial to patients with cardiovascular disease or cardiovascular disease risk. Another recent article, just again saying the same thing, reduction in body weight, improvement of quality of diet, promotion of physical activity. These should be main approaches to prevent and treat patients with type 2 diabetes in metabolic syndrome, at least for a trial. At least the patient is willing and interested in pursuing a lifestyle approach before you go to pharmaceuticals. So we put the patient on modified Mediterranean low glycemic food plan. This great page just came out this year, showed that a greater adherence to the Mediterranean diet seems to prevent left ventricular systolic function. Detection is associated with better long-term prognosis of patients who have acute coronary syndrome. Furthermore, the Mediterranean diet seems to be associated independently with all the conventional cardiovascular risk factors. So what it means is, even though the risk factors maintain the same, but a person maintains a Mediterranean-style diet, there's improvement in prognosis. We added exercise and purposeful movement to our patients' program. And when I say purposeful movement, that means a lot of times we can markedly increase the exercise of a patient through the day without doing exercise. It's, the American Heart Association wants you to do 1,000 steps. So purposeful movement is doing these steps throughout the day by increasing the amount of movement you do throughout the day. And of course, with a patient with multiple areas of his life that are causing stress reduction is really important, because this interesting study in 2007 showed that the risk of distress, so here's general distress, very similar, look at this, to smoking. Now, we know that smoking is a well-documented risk factor, but in this study, having distress markedly increased the risk of developing cardiovascular disease. And this shouldn't have anxiety or anger, but really put him with financial and with family distresses and general distress. So reduction is important. The second we did is we started the patient on Ultramil plus 360 medical food, tubes twice a day, and people say, well, why didn't you go for something for the diabetes? Well, at the moment, his diabetes was fairly well controlled, and in experience, I've gotten very good control of blood sugars by using the 5 Mediterranean diet and Ultramil plus 360. The is highly foundation for patients with cardiovascular risk and disease, and then our patient qualifies. It's made from a very highly refined soy that is not genetically modified. We know that soy helps with cholesterol levels, both at the liver and the intestinal area. It contains 2 grams of plant sterols, beta-testosterone. We know consumption of 2 grams is actually recommended, and you can promote healthy cholesterol levels if you have that in your product. It has the SCRMs, the selective kinase response modulators, in the form of our of RIA from hops and acacia, that have been shown to help the signaling of insulin and help decrease triglyceride levels in our clinical studies. And it activated folic acid, phosphatidyltetrahydrofolate, to help with methylation and to help decrease homocysteine levels and improve cardiovascular health. And it's low glycemic index, so it would be great for healthy insulin functional blood sugar level, and a good way for even a diabetic to start their day. Our study on the HMS3 trial that we did, it's very interesting. So we divided this in, here you have patients that are on style, so they have a Mediterranean diet and 150 minutes of exercise a day, plus Ultramil, essentially Ultramil 360 plus 360 medical food. And then we split out those patients with a high risk of cardiovascular disease because they had LDL greater than 160. This was compared to a group that did the same exact Mediterranean diet. They did the exact same exercise, but they did not do the medical food. And we also then had a group in that population that had LDLs greater than 160. And see that the group that had medical food did much better than the group that did not in total cholesterol. You had a high risk, you even did better. Significantly in the patient, twice as much as the patient with a medical food versus diet alone. If you high risk, you even improve better. The triglycerides the same. The food plus lifestyle change was over twice increase in triglycerides, and they got a better reduction if the patient had an increased risk of cardiovascular disease. And down, each was markedly better than the diet alone. It seemed to be better if you had an increased risk of heart disease. Your total HDL ratio decreased markedly, and the HDL went up almost twice as much as the diet alone, and even increased better in those with a great risk. Now, something very interesting we saw, and that is that patients that had diet alone with the LDL greater than 160 did not either LDL and triglycerides with a diet alone. This was kind of significant. So it's just using a Mediterranean diet and exercise alone, if the patient really has a significant elevation risk of cardiovascular disease, you're not going to see the improvement that you would if you have on a medical food. Which was very exciting at the end of this study was that we looked at the number of metabolic syndrome components, and you can see in the intervention group, both groups, the control and the intervention group, had about 4, but at the end of the study, the intervention group almost did not have metabolic syndrome anymore because they dropped below 3 of the components, and you have 3 of the 5 components to have metabolic syndrome. So I went through the Ultrameal Plus 360 because of its documented clinical effect with cardiovascular risks. The conclusion of our lifestyle management is an effective approach for metabolic syndrome, but the effectiveness seemed to win on the people that were only on a lifestyle program. But when you add essentially Ultrameal Plus 360, you have greater reduction in cardiovascular risk parameters, greater net resolution of metabolic syndrome, and this was quite the same that both groups, the same amount of weight. It seemed like the higher the cardiovascular risk, the greater the benefit was seen, and the probably greater benefit they need a medical food as part of their lifestyle change. So, first-line therapy approach was clinically applicable in patients with risk of cardiovascular disease. So next is omega-3 fatty acids, and I chose high-concentrated DHA. Patient ended up with 2 per day, but you could do a more balanced approach. But the literature is now showing something very interesting. Initially, they just took fish oils and did their studies, and the literature said that fish oils were beneficial. So a study that showed that the combination of EPA DHA, and know that if you could get your red blood cell percent of EPA DHA up to 8.2%, you have a 90% reduction of cardiac arrest, cardiac event. Unfortunately, most Americans are right around this average, between 3 and 4. So, just real quickly, if you don't know, this is a test offered through Metagenics. It's called OmegaQuant, and a lab can actually measure the number of fatty acids on the membrane. In this example, here you can see right here, these red things represent the EPA DHA. So essentially, out of 64, or this ratio would be 4.6 for an omega-3 index. As you saw before, we would like to have the index above 8. Very easy test. It can be done with a finger stick, put on a little filter paper and sent into the lab so patients can do it themselves, and a very good tool to monitor their progress with essential fatty acids. So this is kind of the more modern literature. It just says that high DHA, there's an increase in AL and LDL particle size, which you want, prevent atherogenicis. Didn't seem to hold true with EPA, it was with DHA. A decrease in triglyceride levels, possibly via increasing hepatic glucose output, seemed to be for both DHA and EPA. Decreased heart rate, blood pressure, and platelet aggregation seem to be a characteristic of DHA and not necessarily EPA in several studies. And then, of course, we know that both DHA and EPA decrease inflammatory markers and monocyte adhesion, cell adhesion molecules, so they decrease the endothelial beginning of atherosclerosis. They support the gastrointestinal tract, the immune system. DHA, of course, definitely helps the brain and nervous system and should be used for mothers lactating, anytime you want to improve the nervous system, and it's even good for macular degeneration. DHA is manufactured from squid, so it's a sustainable source, and believe it or not, it's okay for people that have fish allergies, because squid and fish usually do not cross-react, and it's guaranteed quality certified by a third party to be free of pesticides and heavy metals. So I chose high concentrated DHA for this patient, but if you told me you wanted to do more balanced EPA-DHA, I certainly would not be able to argue with you. And then, of course, we wanted to add colon Q10 to this patient, just because the literature now shows that a study reviewing 34 controlled trials and open label including CoQ10, that supplementing with CoQ10 seems to alter the natural history of cardiovascular illness and the potential preventing cardiovascular disease through LDL cholesterol oxidation and by maintaining optimal cellular and mitochondrial function through with internal and external oxidative stresses. And the attaining of higher levels of CoQ10, 3.5 grams per ml, with appears to enhance both the magnitude and the rate of clinical improvement. So this is why I decided this patient, even though he was not on a statin, to add CoQ10 to his plan. So we're at what we call additional treatment protocols, and I need moving here so we get done in the hour. But I would try the initial ones we mentioned over maybe a 2 or 3 month period, retest and see where we are. You'll find that we need maybe to help with the cholesterol more, and the patient does not want to take a statin. We have an extended release niacin. We would start with 500 milligrams and move up maybe to as much as 2 grams over a period of a month or two. Just studies. This top one is a medication that helps prevent the absorption of cholesterol, that when looking at good intimal media thickness, which is an indication of atherosclerosis, niacin worked very well to improve that over 14 months. Try to get up as much as 2 grams of niacin a day, seems to lower LDL, triglycerides, LPL, and seem to have an increasing effect on the HDL, which seems to be more important than maybe lowering LDL cholesterol in the regression of corroded intimal media thickness. This is an easy test that's done with an ultrasound. Again, it's just another study showing the incidence of major cardiovascular events, and the use of niacin decreased the cardiac events almost 3 times when compared to another drug standard drug used to lowering cholesterol. And don't forget that there's recommendations that we need to check baseline liver function tests at least every couple of months until you get the patient stabilized, and then depending who you read, every 6 to 12 months, or from the National Cholesterol Education Program expert panel, at least yearly after the patient is stabilized on the dose of niacin. So we do a formula to support healthy homocysteine levels and cardiovascular effect if the homocysteine level doesn't come down. Articles just show that with increased homocysteine, there's approximately 20% independent increased risk of cardio risk factor. And with patients with unstable angina, folic acid can reduce homocysteine and improve arterial endothelial function, and this seems to have a better outcome with these patients. Very quickly, we're going to go through just beyond homocysteine. because what I actually want to show you is that the key thing is here is 5-methyltetrahydrofolate, and that hydrobiopterin you saw in that slide back at the beginning with creating nitric oxide, very important cofactor in allowing endothelial function and having cardiovascular protection. 5-methyltetrahydrofolate is also an antioxidant, so it's very important to have this active product, and if you block the process, have elevated homocysteine, it usually means that you have a decreased 5-methyltetrahydrofolate, which would lead to increased cardio protection. So 5-methyltetrahydrofolate, beneficial result in improvement on endothelial dysfunction by improving hydrobiopterin use and decreasing its oxidation and improving enos coupling and allowing nitric oxide to be formed. The for improving methylation could be normal is 11 at least for homocysteine, but in clinic we like the homocysteine level to be lower than 7 millimoles per liter. When I use this product, it supplies all the nutrients needed for a healthy methylation and homocysteine and folic acid cycle. And again, after testing and using the Ultramil Plus 360, you might want to go to a more specific product to improve methylation if your homocysteine level is not where you want it. You add, if the blood sugar is not being controlled, an advanced formula that is green tea, cinnamon, and alpha lipoic acid. The green tea helps with insulin secretion. The cinnamon helps with support insulin activity. The alpha lipoic acid is an antioxidant and a free radical scavenger and enhances insulin sensitivity. And targeted nutrients support healthy glucose metabolism and provides an antioxidant profile to reduce oxidative stress and promote healthy insulin action. So you might add this product twice, 2 tablets with each meal if the patient has not brought blood sugar under a target level. And depending on religious belief or personal beliefs, 1 drink of water a day, and I look at these studies. If you real quick, you may not be able to see them, but all these studies show a markedly decrease in cardiovascular incidence, myocardial infarction, from cardiovascular death with mild to moderate alcohol consumption compared to non-drinkers. So, some patients, this may be an important addition. For hypertension, I'm just going to go over this very quickly because we have some products and you may want to address hypertension if this still becomes a problem. So you may want to change the diet a little bit. Higher potassium, low sodium, rich in fiber and fruits. We want to avoid too much alcohol and caffeine. We want to increase the consumption of onions, garlic, and celery, which tend to help decrease hypertension. Magnesium is excellent in decreasing hypertension, so you may want to add a chelated form of 400 to 800 milligrams a day to this patient. You saw L-arginine was a precursor to creating nitric oxide. So taking L-arginine, 2 tablets twice a day, may be a good strategy to try to improve nitric oxide formation and allow blood vessel relaxation. And then an anti-angiotensin converting enzyme peptide we have from bonito, a fish, maybe tablets a day, sometimes can work in conjunction with the above to help decrease hypertension. So, looking at the picture, therapy, all meal, 360, 2 scoops a day, type of EPA DHA at least per day, trying to get up to 1 to 2 grams a day and try to get the EPA DHA index up to 8%, Q10. After a trial, if you still need additional help, extended release niacin. You know, I work on 500 milligrams with food, going for weeks, and the increases, you might get the patient up to 1,500 to 2 grams a day to bring down the L, maybe homocysteine support, maybe support for healthy glucose, maybe magnesium, L-arginine, and anti-ACE peptide to help with hypertension. Covered a lot, and I just gave you some excellent food thought, but this isn't a way to approach a patient with high risk of cardiovascular disease, their diabetes. So thank you. And Irene, do you have any questions that have been submitted?
Yeah, we do, Dr. Kornberg. We have a question here. How long does it take for the flushing on the low dose of niacin to diminish? Okay,
so this is not low dose niacin. This is a 500 milligram dose of niacin. It's very similar to Niapan, what we call an extended release. It's not a sustained release, so it doesn't have the same liver toxicity we're seeing in the literature that the release does. We used a fiber encapsulation to help slow down the release to help slow the flushing. But to the question, most people will flush for about a week to 2 weeks. So you would start with 1 tablet with pills and expect the flushing. Flushing again is from prostaglandin. It's not from histamine. And there's some literature that says people can take even aspirin. They can take maybe they can take Caprex. Anything to block prostaglandins seems to help. But in a clinical trial, the flushing was not intolerable, and after a week or 2, the flushing went away. And then about 4, you'd maybe want to increase the dose again. You'd give them 2 tablets. They'll have flushing for another week or 2. They'll go away, and you'd want to probably the maximum dose I'd recommend, maybe about grams. Of course, you're checking liver functions, and you recheck the target cholesterols and see where you were.
Thank you. I have another question here, Dr. Kornberg. At what point should we be concerned that cholesterol is getting too low?
Anything under, personally, I don't have to see the cholesterol under 100, total cholesterol. Don't forget, and I think especially in elderly people, I've seen people who are 90 years old where some doctor wants to drive the cholesterol very low, and I think that's not a good idea. Don't forget, cholesterol is the precursor to every one of major steroid hormones, and there's some literature way back that low cholesterols may increase the risk of other diseases like cancer. So I try to keep, I'm not convinced that cholesterol is the bad guy. So I want to reiterate that inflammation is our culprit. So when I approach a patient, I'm looking at how can I decrease inflammation. So I think that high-sensitive CRP, some of those other markers are more important than actual total cholesterol. Remember that study that showed that half of the people that got admitted to the hospital with cardiovascular events had low LDL, way 100. So trying to drive the cholesterol down, to me, is not appropriate. And, we have those studies from Canada that said to treat people to drive cholesterol down, you have to treat 100 people for one person not to have a cardiovascular event. So that's my take on it.
Oh, God, we're getting a lot of questions here, Dr. Kornberg, so let's just try to move on. I have a question here. Isn't it better to use citrulline because of degradation issues of arginine?
We have not. You can, but citrulline is after, and I believe you need the arginine. Is part of the. We use arginine. We found it to be very, very, very good. And most articles will talk about something with arginine, not citrulline.
How about what form of magnesium would you use for cardiovascular issues?
A chelated form, glycinate, or one of those.
Here's another one. Here's a good one. Would you recommend consumption of niacin if you have gout?
Well, you have to you have to watch carefully because there's studies that show that niacin can increase symptoms of gout. So probably that would not be my first go-to in a patient with gout.
Okay. A good one. Should the wine be red?
Actually, the literature says that it even happens with hard liquor. Of course, red wine has its own antioxidants, but the studies that actually did studies were not necessarily with with red wine. And I think there was one study that showed that it did not make a difference what color the wine was to have the cardiovascular protective effect.
So, let's see, we probably have a couple more to answer. Could a high EPA-DHA ratio still help with cardiovascular disease as long as the DHA dosage is sufficient?
Yes. So I'm assuming somewhere that we're more equal EPA-DH ratio? Is the question?
Well, it just kind of high EPA-DHA ratio still help with CD as the DHA dosage is sufficient. They say it should help with inflammation. Is that correct?
Yeah. So now, what we want to do, the literature really shows, I mean, from the Zealand study and a couple studies from the Mediterranean, that we're really looking at about 2 grams of EPA-DHA per day to equal what the intake is in all these studies where it was cardioprotective at a higher dose. So you're really talking about getting a patient to take several capsules a day. And so what I've done in my patients, I will give them maybe 1 capsule of high DHA, and then the other 2 capsules be just regular, more balanced EPA-DHA. Trying to get a total of about 2 grams in per day.
Okay. Can you have a couple more questions?
I'm here for you.
Okay. What causes low HDL in midlife females, and how do we support increasing it?
Sometimes, you know, I found that sometimes the cholesterol, one thing, it can be related to hormones and or lack of exercise. So exercise has been a classic way to try to increase HDL. HDL has been very hard to regulate by drugs. I mean, it doesn't do a huge job. Well, we're very surprised to see how well Ultrameal 360 and a Mediterranean-style diet increased the HDL. But what we saw is that the HDL went up when we started adding exercise. I had some patients that had to deal with estrogen level problems before their cholesterol kind of leveled down. Actually I've actually used this. Maybe they have low progesterone. Believe it or not, there's some studies that show that progesterone can help modulate that. So maybe, as you looked at everything, an approach might be, does this lady need in midlife going to change? Does she need a little progesterone? I've actually seen it in both males and females have the HDL come up and the cholesterol go down when couldn't budget it very much by days. So that answered the question.
Do you find a strong connection between these precursors for heart disease and lung dysfunction as exists with congestive heart failure?
Repeat that again.
Do you find a strong connection between these precursors for heart disease and lung dysfunction as exists with congestive heart failure?
Yes. I mean, so you get, you know, with hypertension, you get pulmonary hypertension and you get left ventricular hypertension, which decreases the cardiovascular output. And, you know, decreased cardiovascular output and cardiovascular failure is what leads to a congestive heart failure. But I want to throw something out because we're going to talk about it in a couple sessions. Interesting studies show that intestinal hyperpermeability, so the endotoxemia that comes from improper gut lining has a great deal to do with congestive heart failure, and by decreasing gut permeability, they markedly decreased episodes of congestive failure in those patients. So not only have the risks of cardiovascular disease such as hypertension, but there's other risks in the body that lead into cardiovascular dysfunction.
Thank you. We have two questions. How can we find out how to get and incorporate the Omega Quant test?
Your Metagenics representative, sales rep, should be able to tell you how. We've made some kind of a relationship with the company. Talk to your rep, and you should be able to do that. I mean, or you can go online, and I think you can just go on omegaquant.com to find out more information.
Okay, last question. Could you go over the Framingham risk score and how do we calculate the percentage of CVD risk? Could you just
you have to do it. All you do is Google Framingham risk score or Reynolds risk score, and there are several free spots that have the calculators already on the computer. And so what you would have to do is you enter the patient's age, you enter the patient's systolic blood pressure, their cholesterol into this little computer, and it puts out the Framingham risk study, or Reynolds, it'll do the Reynolds. So you get those right offline. They're free, and there's several companies that have them right there up front. So that's what I would do. You have to calculate it yourself. And I believe for cardiologists and stuff, I think there's downloadable programs that you can put on your little iPad or whatever, but that's how you do it.
Great, thank you very much, Dr. Kornberg.
And I look forward to seeing everybody in 2 weeks.
Thank you all.